people want to be seen and their problems acknowledged. You use AI or other computational tool to extract those insights, but then you need to make that leap from insight to adoption and scaling, right?
Welcome to the Chief AI Officer or CIO Podcast, where AI mentor Sanjay Puri talks with the leaders shaping tomorrow's technology. We explore their stories, challenges, and big ideas driving change. So if you're curious about how AI is transforming work, business, and everyday life, this is your front row seat to the future. Today on the Chief AI Officer podcast, we're joined by Dr. Girish Nadkarni, Director of AI Strategy and Innovation at Mount Sinai Health System. A physician scientist and technology leader, he is driving how AI transforms patient care, clinical workflows, bringing a unique perspective at the intersection of medicine, data, and technology.
Girish, welcome to the CIO Podcast.
Thank you so much, Sanjay. It's a real privilege and a pleasure to be here.
So, just very briefly, if you can just tell them how you got to this point from where you are, because you have a very interesting background.
Yeah, so a lot of it is serendipity. Uh, I strongly believe that life is how you react, what happens to you, right? So I trained in India. I grew up in India, in Mumbai. It was called Bombay back then, and I did my medical school in India. And as you know, Sanjay, sort of in India we have this interesting system where until high school you study both maths as well as biology, and then you make a this, and several of us sort of sit for the entrance exams of both, right? So I did sit for the entrance exams of both mathematics but also biology. My parents were physicians, and sort of having those role models in the house, as well as being exposed to healthcare from an early age, both personally as well as professionally, through my parents, I decided to go into medicine. Um, and then when I finished medical school, I immigrated immediately after to the United States, where I did a master's at Johns Hopkins in informatics and biostatistics. It wasn't really called AI at that time. And then I came to the Mount Sinai Health System and the Icahn School of Medicine in Mount Sinai, where I was very fortunate to be in a system that was already thinking about the future, and more importantly, trying to create the future that they were thinking about, which is sort of rare, right? So I was very fortunate to find mentors in Mount Sinai, both on the computational side as well as on the clinical side, who were thinking about how healthcare could look like, 10, 15, 20 years from now, and trying to instantiate it right there. So I did my residency and then my postdoc in Mount Sinai under Dr. Erwin Bottinger, who's now the CEO of the Weiss Institute. And he was sort of instrumental in making me think about how, not just how medicine you could improve medicine now, but how you could sort of pull the future forward, right? And then did a postdoc for 2 or 3 years in personalized medicine and informatics. And obviously, because personalized medicine, AI, and informatics were integral to the future, I got plugged into various system initiatives, sort of, and maybe this is not a good thing to do, but anytime anyone asked for anything, I sort of put my hand up and said, I'll do it, right? But then the real turning point came during the COVID pandemic, when the Mount Sinai Health System was the epicenter of the epicenter. And at that point of time, we actually truly sort of took steps towards becoming a learning health system, because we didn't know. We were like finding out, disease trajectories, diagnosis, therapeutics in real time, and data and computational tools to analyze and sort through that data were critical at that time, because no one knew anything about this disease. We were discovering knowledge and applying it in real time. And that's how sort of a learning health system evolves. And, it was a challenging time, but like challenging time is when characters, not just me, right, but like everyone at Mount Sinai truly shone. And after we sort of through the COVID-19 pandemic, you know, there was a renewed there was already lots of interest, but there was also a renewed interest in this in the field of AI and computation and big data, which sort of led us me to take several, with the help of many people, to take several steps in order to think about how we're going to use these tools in clinical practice, in health science systems delivery, in research, all of the in education, all of the tripartite missions, um, uh, uh, and then when the department chairmanship opened up, I applied for it, and the school and the health system leadership thought that I was a good mix of sort of both the AI expertise but also the clinical expertise in order to help steer this in the right direction. And when the chief AI officer opened up, it was an it was an ideal marriage because in most large institutions, you have the academic side of things, and then you have the clinical and operational side of things. And there are silos, but at Mount Sinai, thanks to our leadership, they sort of flow together. And that's why Lisa Stump, who's our CDIO, sort of had this vision of integrating AI across the enterprise, what she calls from um, the bench to the bedside to the back office and back again, right? And that's why, under her leadership as well, and under the leadership of our CEO, Brendan Carr, we decided to sort of integrate AI, informatics, precision medicine across the health system, starting obviously with the low risk clinical tasks, but also low risk non clinical tasks, I apologize, but then obviously doing it to improve clinical medicine, healthcare delivery, and ultimately patient lives and outcomes, which is what we all hope for.
Oh, wow. It's been some journey all the way from Mumbai uh, up to New York. And as I think some of the points you said was you raised hand, and sometimes you just have to raise your hand, even if it can be challenging and you know, cross so many uh, different opportunities. And as you said, strong leadership, and we'll come to that, has really helped being at the epicenter of the epicenter, which was during COVID. You mentioned learning health system that Mount Sinai is transformed into a learning health system. So for our audience, can you just break down what does that briefly? What does it mean? How does it differ from a traditional healthcare AI initiative?
Because of the digitization of everything around us, we collect a ton of data on every aspect of our lives and every aspect of our healthcare. But we don't really use that data well enough to make decisions because medical care right now is kind of episodic, rests on a few data points, and is not using learning as a fundamental principle where you learn from each interaction, where you learn from each data point, where you learn from each patient to improve the lives of every patient, right? So the fundamental thing of a learning system at its core is you have this amazing amount of data, healthcare operations, what have you. You use AI or other computational tool to extract those insights, but then you need to make that leap from insight to adoption and scaling, right? And in order to do that, you need to know which insights actually work in clinical practice. So there's this testing and evaluation layer where you adopt practices that have been ongoing for a long time in tech industries or social sciences industries like A/B testing, rapid cycle testing, in order to rapidly test different approaches in an iterative fashion. And when you find out what works best, is then when you have the when you decide to sort of adopt it and scale it, right? And I don't want to give short shrift to the adoption and scaling because that, to me, is the most difficult part of the enterprise because that requires culture change and that requires a sort of a culture where you're allowed to fail while you're experimenting as long as you learn something new and you learn something valuable. And there's a psychological safety component about it, right? Like, for example, if you have a culture in which you're going to be dinged for every mistake that you make, the corollary to that is you will never learn anything new, just because of the fact that, the only way to learn something new is experimenting and like figuring out how it works, right? And I think our leadership at Mount Sinai realizes that, so they're instituting culture change where you take multiple shots on goal, but do that rigorously and do it measurably, so you can actually figure out what works, and then you adopt and scale it, right? So I think that a learning health system has sort of several layers. Data is obviously the critical layer, but then insights from the data, testing those insights, and then adopting and scaling it across the enterprise, which generates new data and sort of sets off this virtual cycle where you go from data to insights to practice, generating new data, all underlaid by a culture of psychological safety and allowing you to experiment.
That's great. So, as you said, data, insight, analytics, adoption, execution, and then obviously, uh, you know, a culture change, which, as you said, multiple shots at the goal. Coming to culture change, in the conversations we have with leaders like you across enterprise, AI is transformative, technology or whatever you want to call it. In your role, change management or dealing with a change in culture, how important is that, and what skill does someone, this is for your peers because a lot of your peers are listening, what skills one needs to have to deal with people during this massive change of culture process?
We have this process all wrong, right? So we think like what happens usually is the leadership thinks that there's a problem that we need to solve, and we build a solution for that problem without, um, uh, without talking to anyone who's actually having the problem or mapping out their workflow. And uh, and then we are very surprised when that solution doesn't get adopted or scaled, right? What I'm saying is, I think we should flip this sort of the paradigm a little bit, because if yes, you can have a bigger goal, right? Operational efficiency, improve patient outcomes. But if you talk to the end effectors of that goal, right? What is it that we can solve for you? Like on a day to day basis, what's your workflow, and what parts of it you think can be helped or augmented by technology, not just AI, but any technology? I think that is critical. So, what I'm trying to say, I guess, is that involving the end users of any technology in the ideation, the development, the planning, the deployment, and the adoption phase is going to be critical, because that sort of breaks down two barriers, right? The first barrier is that people want to be seen and their problems acknowledged, right? And if you do that, then they are much more likely to adopt that particular technology. And the second thing is, and it's linked, is that if people adopt the technology, they also become evangelists for it, right? They also become like messengers to the larger community, right? Like, for example, I'm an emergency room physician, and I was like, I was involved in all the phases of this, and it worked for me. I'm going to go out and tell five physicians, right, that this really worked. You should really try it. And those five physicians are going to go out and tell five physicians each, and it sort of becomes this exponential word of mouth effect, right? Because I think one thing that, and this is again, our CDIO Lisa Stump has taught me this, that change management is critical, but change management is is difficult, not because people are afraid of change, but people think that they will be left behind with that change, right? So if you sort of meet people where they are and include them in the change management process, that becomes this self-perpetuating flywheel where people adopt it, to tell other people about it because they've been involved in it, people, and because other people trust them, more people adopt it, so on and so forth, right? Um, Now, obviously, I'm just talking. You can obviously dictate from above, that you have to use this, and sometimes that might be necessary for regulatory or other reasons. But for things to actually people to adopt it as opposed to just click on a box and move on, you have to sort of involve the end users of the technology. And these are not new ideas, right? You know, people, when Apple designs a product, they obviously talk to like thousands of end users of the technology, right? And like, uh, see what they want, focus groups, etc., etc. So I think that this is going to be critical in terms of uh, broad adoption and scaling, right? And finally, and this might be the most important point, is that people have to find the technology useful to themselves, right? To have, like, I think we've talked before, right? AI is an arbitrage of knowledge for time, right? They have to find that this technology is useful for themselves in either saving time or giving better time to make better decisions for their patients, right? If and if people don't find this technology useful, they'll check a box and move on, right? But if you make technology useful for them, and particularly for their own workflow, for their own uh, 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 in the way that they do things, that's the way to adopt and scale. So I can't stress this enough, is that include end users or the end effectors in every step of the development and deployment process, and that they'll just be evangelists for your technology, right?
So, as your CDIO said, meet people where they are so they don't feel left behind. And you said, find the uses for them because AI is arbitrage, you said, for what was the word you used? I thought that was a pretty cool thing.
So if you think about AI right now, right? I mean, if you think about its technological revolution, right? There was, you know, earlier there was a mass of data. Then with search, the data got turned into some sort of information where you could click on links and access information of organized data, right? But I think AI is like one step above, in which it's actually encoded knowledge where it can give you useful answers, as opposed to just links in answer for your questions, right? And then, we are sort of getting to the next step above that, which is agency, right? Where instead of like you having to effect a change, AI agents can actually take that next step for you, right? But I think that, well, there's a one more step about that, which is wisdom, right? And I think that's a uniquely human characteristic, because that's bounded by, or not bounded, that's informed and by ethics and morality and our innate humanness of things, right? And wisdom is where you use them, it's choice, right? You do it or you don't do it, or you do it in a different way, right? And I think that is where our innate humanness comes forward, is like, yes, there's AI is this incredible knowledge engine where, you can give it questions and it can give you back answers and save time, right? Or it can predict what's going to happen to a patient 2 hours before, so that you have 2 hours to make a decision as opposed to like 2 seconds, right? But at the same time, ultimately, the wisdom to do important things with your time, or the wisdom to take actions, or the wisdom to, save lives, is innately human thing, in my opinion.
When you look at things like cloud and some of these other things across enterprise, ERP and stuff like that, they were generally a top down approaches to the enterprise. Do you think this I don't know how it is in your organization. Do you think this should be maybe a bottom up also rather than just a top down approach? What is your perspective on this with what's happening in this transformative technology?
Yeah. So again, and I want to give complete credit to our CDIO, Lisa Stump, and who believes in the experience-led model, right? And by definition, experience-led models have to be somewhat of a bottom up or a middle out approach, which is by meeting people where you are. Obviously, if you may not be able to fulfill 100% of 100% needs for 100% people, but if you meet them where they are, you can maybe fulfill 80% of 80% people, which is a win, or 70% of for 70% people, right? So I do think that the two things, right? One is ERPs or cloud based systems, yes, have been traditionally top down, but we are in the midst of a revolution where they can be hyper personalized by either building them from the ground up, and we can talk about, or having sort of knowledge slash layer on top, which can personalize it to each individual people's needs, right? And that I think would be super useful thought. I think that's transformative because instead of maybe meeting 10% of needs for 100% of people, you can at least meet people where they are and like meet most of their needs, right? And there's lots of commonalities in there, but again, sort of this experience-led design leads to a lot of value creation, both in terms of productivity, but also in terms of the experience that people have when using these tools.
So let's now switch to another topic which a lot of your peers have sometimes challenges with, which is securing executive support or leadership support and then ROI. You clearly achieved remarkable C-level support at Mount Sinai, from hosting the inaugural Mount Sin AI retreat to establishing an entire Sinai retreat, to establishing an entire department. For your peers who are listening, are there any specific metrics or business cases you use to convince your leadership that AI deserved this level of investment and organizational commitment, Girish?
Start off with the why. Why are you doing this, right? What is the problem that you're trying to solve, and is it tractable to uh, technology, but also tractable to operational readiness? You have like this thing, right? Technology might be there, but operational readiness might not be there, right? And in that case, you will never scale beyond pilot, right? So you should start focusing on those things that are in the top right of that quadrant, where the technology is ready, but the operational readiness is always ready. And these things should be things that people don't enjoy doing. Drudgery, repetitive work, etc., etc. People don't really enjoy doing that because then that frees them up to do more creative, top of the license things, right? That's one. The second thing I think is demonstrating technology as to leadership is useful because if they see themselves what they can do, what technology can do, be it voice agents, be it data clinical data extraction, right? They'll be much more likely to be an evangelist for this particular. And the third thing is you have to have a good ROI calculation, right? The return on investment calculation. And the ROI just doesn't need to be financial, in my opinion. Right? Obviously, financial ROI is the easiest to measure and the easiest to quantify and is important to health systems, especially in these times. But there are other ROIs, right? For example, I'll give you an example. Ambient scribes, may the financial ROI is not as high as expected, but they have ROI in different aspects, right? They have ROIs in burnout, they have ROIs in clinician satisfaction, they have ROIs in patient satisfaction because clinicians and patients are talking more to each other as opposed to like a clinician typing on the computer, right? And that helps with retention of your workforce, right? Because if someone leaves, replacing is a longer uh, uh, time. There's a sunk time into that. There's sunk cost into that. There's opportunity costs, etc., etc. Right. So I think that like the three things just to sort of repeat is one is start off with the why. Why are you doing this, and what problems are you trying to solve, and make sure that those align with the problems that the leaders are trying to solve, right? And there's a lot of commonality there. Most health systems have the same problems that we're trying to solve, right? Length of stay, etc., etc. Second is show them the capabilities of the technology, be it even demo form. And the third thing is sort of quantify ROI, but I think moving beyond financial ROI, thinking about retention, wellness, preventing burnout, reputational ROI, all of those things, which is what things leaders think about all the time.
Are there any models that you use? for that other chief AI officers who are listening could adapt, or frameworks like your delirium prediction models or admission forecasting systems? What do you use from an ROI perspective that obviously you can talk about that can be helpful to your peers here?
If a model leads to increased billing or coding or reduced length of stay, that's a direct financial ROI that you can calculate, right? And that is a simple mathematical or financial calculation that you can do. So you should do that upfront, right? Then you'll have this category of technologies where you might not lead to an increase in the bottom line revenue, and there might need to justify investment, and that's where qualitative measuring of ROI comes in, right? And that's where, again, coming back to our earlier discussion, you need to go to the end user and ask them qualitative research questions, right? Is this technology more likely to I'm just giving examples. There's standard quantitative frameworks to assess on this and this. Is this technology more likely to, make you better at your job? Is this technology likely to lead to job satisfaction? And you don't need to do it for everyone. You can do it for a representative group of users, and basically um, then show that using of this technology was likely to lead to higher job satisfaction, decreasing feelings of burnout, and that leads to more retention. And then also sort of becomes financial calculation, right? If you were to improve retention by 5%, this is how much money the health system would be saving just in dollars. And then the add-on is that you could prevent X amount in opportunity cost, X amount in time.
So talk to the users, have good quality data, I think is some of the messages you're giving. Girish, moving to AI governance, which is obviously a very important aspect, especially when you're dealing in healthcare or some of these other industries. Your recent research showed that large language models change their ethical decision based on demographic cues. It's a finding that has huge implications for enterprise AI governance. Has this research shaped your AI governance framework at Mount Sinai? And what practical advice would you have for other chief AI officers who are dealing with bias in their AI systems?
AI broadly, and this is not completely true, can be classified into predictive AI, where you're making a prediction or a diagnosis about a patient, and or generative AI, in which it's more of generative or agentic AI, where it's more of a non-deterministic, non-rules based approach, right? So talking about the first, um, biases can exist in there and can actually be worse than generative AI because they are sort of unseen to the end user and the consumer. They just manifest in actions taken for a patient or a group of patients, right? So for those, you need assurance by demographic subgroup, by age, by all of those things. Even before you deploy it, one of the best ways to do that is a silent trial in which you run the algorithm in the background, see what the performance is by overall and by demographic subgroups, and then think about whether you need to actually do like a A/B test or a trial before implementing it. But after implementation, you need to do post-deployment monitoring with regular intervals, um, um, uh, in order to make sure that there's no drift, right? So that's one. The second is more sort of generative thing, and their approaches like red teaming, benchmarking, human in the loop come in, where you sort of try to benchmark it against existing data and try to red team it, trying to break the model so that you have guardrails, because then you can come up with a set of guardrails that you can implement into the system prompt and prevent it from doing these things, right? Now that's not going to be an exhaustive list, because by definition of this algorithms and non-deterministic aspect of them, and the fact that this algorithms change regularly, you can have that. And that's why regular monitoring by humans is going to be critical. Like, for example, if you have an agentic or a generative AI system that's responding to questions, a human will look at a you know a f- um, the last week of messages and see, then run them through a standard bias detector and see if there were any biases, right? And if there were, you should do that. So I think assurance before deployment and regular monitoring post deployment. Now technology is changing on a regular basis, so I think we're going to experiment with generative adversarial networks where one network or one algorithm is trying to catch biases in the other. And that I think will help scale it. And there have been a couple of new research papers on that, but it's not quite production grade yet.
So that's really helpful to know. You brought up AI agents several times, so let's go into uh, that discussion. It's one of the hot topics in the enterprise world. How do you see autonomous agents fitting into healthcare workflows, and what are some of the challenges? Because these are autonomous agents, and especially deploying it in such a high stakes environment, Girish.
All of healthcare decisions are not going to be high stakes, right? So if you think about sort of a few different domains, right? How fast the decision needs to be made, how reversible it is, how critical it is, and how close it is to patient care, right? So, if you think about that as sort of a risk rubric or a framework, if the decision needs to be made fast, it's very low criticality and very easily reversible, and it's not related to patient care, then you can think about autonomous AI agents, obviously with pre deployment assurance and post deployment monitoring with human in the loop, right? Now, if you think about the reverse side of this, right, where the decision can be made not super fast, but it's extremely non-reversible, extremely critical, and putting into like and affects patient care immediately, like doing a surgery, right? There is where I think you have to have sort of not just human oversight, but human control. They can surface recommendations to you, but the ultimate decision needs to be on a human thing. So, like autonomous things is a scale. I think the risk rubric on which you need to make these decisions is also a scale where you, on one hand, you have decisions that need to be made very quickly, but are non-critical, quite reversible, and not close to the patient. And on the other side, you have critical, non-reversible, very close to the patient decisions. And that's where this, autonomous agents should not be used, or if they are used, need rigorous human oversight.
So obviously, rigorous human oversight on critical areas, but non-critical they can be used. And you said there should be a human in the loop. You did a Mayo Clinic study which involved over 500 nurses in a human in the loop AI system. Um, this is the kind of workforce integration that chief AI officers deal with. Tell our listeners a little bit about this study. What did you learn about from this study?
This study was done by Robbie Freeman, who's sort of my partner and the Chief Digital Transformation Officer, and Jonathan Nover, who's the VP of Systems Operations. So, a simple premise, like when people come into an emergency room, who can predict better whether they should be admitted or not? Is it a LLM or a nurse? And we found that LLMs perform equivalently at the level of a nurse, right? And that is actually an interesting finding because it's the first time that you used sort of LLMs alone, LLMs with humans in the loop, and humans in the loop alone, and the performance was equivalent, right? And this is an example of a decision that could use AI support, right? Because it needs to be made fast. If you don't make it fast, then you have people backing up in the emergency room. It's it's critical, but like also reversible, right? Because if you admit someone, you don't need to. You can always discharge them or transfer them to another floor, etc., etc. And it's close to the patient, but at the same time, there's inadequate human oversight over it with the doctors, nurses, and physicians, right? So I think that like for decisions like this, what we learn through the study and many others is like you can actually give um, sort of just triage decisions which need to be made fast with the help of AI and like accept and reject recommendations very easily. As so, I think that now the next phase is going to be to figure out which are the use not the use cases but also like the domains and the clinical scenarios in which AI can be used safely. And thanks to Robbie and Jonathan, this was the first study to show that.
There are new models constantly getting released, whether it's ChatGPT 5, Grok 4, Gemini, Llama, etc. How do you and your team evaluate which models should you deploy in clinical settings? How do you manage the cost of inference, GPU scarcity, and also exit ramps to avoid, you don't want to be locked into a vendor. So, any thoughts for your peers on that, Girish?
With open source models, there's little bit more transparency and a little bit more control. But at the same, and they have caught up in terms of performance to open closed source model. But the question is, for your particular use case, which performs the best and which has the least amount of negative second order effects, bias, etc., etc. And that needs to be benchmarked. And there are tools now for benchmarking those fast. Um, the second thing is sort of GPU scarcity, right? So we are very fortunate at Mount Sinai because thanks to Patricia Kovacs, we have the largest supercomputer in the New York area, and we are also part of the Empire AI consortium, which is building like a huge, the largest academic supercomputer. So we are very fortunate to have access to compute. But I think the costs of inference are dropping because of quantized models, small language models, etc., etc. And you can do tweaks like just talking about agentic AI. You can have small language models to do specialized tasks orchestrated by a large language model. So the large language model can actually um, doesn't require that much compute because it's just orchestrating, and the small language models that can run on a single GPU are doing most of the heavy lifting. The second thing that, and I'll send you this paper, is that you can actually batch tasks and run tasks in batches as opposed to running tasks one at a time, because that reduces the number of tokens and decreases the cost required a lot. So there are strategies in order to reduce the cost, and this just requires smart architecture and a little creative thinking. So that's how do you think about the cost, etc., etc. Ultimately, I think which model you choose or which architecture you choose depends upon your use cases. You just have to have a framework and infrastructure in order to do this sort of creatively. And I think the big providers, be it AWS, Azure, or GCP, are providing this sort of primitives where you can like pick and choose what you want for your particular task. But I think the non-negotiables are assurance before testing, picking the right model and right architecture for the right task, and deploy and sort of post-deployment monitoring.
There's a real premium on, you know, quality AI talent. You're competing, especially with tech giants for AI talent while you're building your teams. That especially in your case, they need to understand AI as well as healthcare domain knowledge becomes important. So, how do you attract and retain this kind of talent when you're not probably offering Silicon Valley type salaries? What is your value proposition? And also, this is an opportunity for you to tell your audience, the kind of people you look for and why some of these people should be reaching out to you to work at Mount Sinai, which is a cool place to work.
Health systems are the place to make an immediate, measurable, and visible impact on care, right? Because health systems treat millions of patients per year, and health systems uh, uh, have are the sort of the front door for a bunch of patients. So I think you attract mission driven people who actually want to make immediate visible care by the use of AI, and I think those are the people that we actually do want to attract, right? Because yes, you can get much higher salaries, but the job satisfaction is probably higher here. In terms of sort of what talent you should think about, not just for me but for everyone, yes, you need like AI scientists and AI developers who are and MLOps people who are very conversant with um, this, but you need a bunch of different phenotypes, right? You need implementations people, who can actually think about how to implement this so that it sort of is primed for scaling and for adoption. You need um, clinicians who sort of are thinking about places where AI could be useful because they are sort of on the front lines and are seeing the issues. You think about uh, 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 informatics people who map workflows and figure out how to put in informatics, AI informatics solutions for a bunch of different problems. You need to think about qualitative researchers, right, who do all of the qualitative tasks that we're talking about. And you need storytellers. You need people who can actually tell good stories in order to inspire and people to adopt the solutions, because there's a fair amount of just stagnation, not just stagnation, inertia, and you need stories to move past this inertia, right? So, yes, AI developers and ML ops and AI ops people are critical. By the same time, in order to build like a functioning organization, you need all of these different kinds of people, right? And I think there's enough people in the world who are mission driven. One more thing is also it's been never been easier to build things now than before, right? So the you know you and I have talked about this with the new coding tools. It is easier to build stuff uh, much than before, and it's an awesome opportunity for people who are at the start of the career to come in, make a measurable difference, actually see the impact of your work on people's lives and uh, health. And then, if they want to move on, this is sort of will be a rewarding opportunity.
That's great. So, different kinds of background, clinicians, AI, ML folks, bioinformatics, informatics folks, um, and people who are mission driven. I think that's what you're saying is that's the secret sauce for you. One of the questions that came from your peers was about picking, how do you figure out which use cases to pick? Because there are thousands, in some cases, hundreds, thousands of use cases. And then how do you take these to pilots and to across to system-wide deployment? Mount Sinai is such a massive health system. Uh, what, are there any measurements or any, ways that you look at which use case to pick, and then how do you scale them up from pilot to system-wide deployment?
Use case again has to be measured on technological readiness, but also operational readiness and adoption. And you have to start off with the why, right? What problem are you trying to solve, and does it align with the larger goals of the health system, right? And if it aligns with the larger goals of the health system, and people are primed and ready in order to um, implement that solution, you'll have a much easier time uh, implementing and scaling that solution than if you don't.
The problem that you're trying to solve, I think, is what you're basically saying. That should be the most important issue in there. One of the other things is, you have done collaborations, with the Hasso-Plattner Institute and other tech partners. This is relates to partnership strategy with technology companies and others. How do you structure these partnerships to ensure that knowledge transfer retains while you retain control over your AI strategy? What should chief AI officers look for when they're forming these strategic technology partnerships?
So every partnership is different, but just in some sort of principles is like what is each individual entity building the partnership, and in that case they should be fairly compensated both in terms of resources, time, but also the upside. Like if you're co-developing something, you should have common equity in it so that you participate in the upside, right? And also it's also sort of like a jigsaw puzzle, right? Filling gaps between each other, right? Like, for example, the Hasse-Plattner Institute in Germany, which is our most valuable partner, has extreme strengths in computer science, cybersecurity, digital design, while we have strengths in implementation, scaling, clinical expertise, right? And so it was a perfect fit. So I think try to find those places where things fit, right, rather than forcing partnerships, but make sure that there's fairness on all sides.
So make sure there is a good fit and fairness on all sides. That's very, very important. as we wrap this up, we do a lightning round of questions, basically one word answers. This is for our audience that uh, likes sometimes to put our guests on the spot, but that's not our intention. So, are you ready?
Yes.
Okay, so what is the biggest AI risk in healthcare?
Hype.
Hype, okay. Python or R?
Python.
On-prem or cloud?
Hybrid.
Okay. Transformer or CNN?
Transformer.
GPU or TPU?
EPU.
Okay. Supervised or unsupervised?
Self-supervised.
Okay. Open source or closed source?
Open.
Open, okay. RAG or fine tune?
RAG.
Okay. Multimodal or text first?
Multimodal.
Okay. Agent or assistant?
Agent.
Large language models or small models?
Combination.
Combination. Okay. Synthetic data or human data?
Human.
And then the final one is privacy or personalization?
It's a hard one.
That's a hard one.
Private personalization.
Okay, that's good. So Girish, our listeners are, a lot of them happen to be chief AI officers, AI leaders who are, implementing AI within their organizations or going to be doing that. From your experience and based on what we have discussed, talk about one specific advice. And also I want to hear, what is the maybe technology or AI solution that's, in your view, that's on the horizon that excites you most?
So one specific advice would be, think about building infrastructure that spans the enterprise, not just point solution, and build to scale, not to pilot, and use and do so involve end users and communities in every step of the process. And one future thing that I think is going to be super useful, and this is sort of a little bit out there, is graph learning or graph neural networks, which move beyond the linear understanding of transformers to more of a world model understanding of the world.
Okay, so graph learning is the thing that we should be looking out for, and our audience should be. Girish, thank you for sharing your insights with our the Chief AI Officer podcast community. Your work at Mount Sinai truly demonstrates that successful enterprise AI is not just about having the latest and the greatest model. It's also about building systems that integrate into human workflows, respect ethical boundaries, and, as you said, deliver measurable value, answer the why, as you said. And for our listeners, Girish's approach really offers a masterclass in enterprise AI implementation. Start with the why, invest in human in the loop design, and never compromise on ethics and bias testing, and always measure real world outcomes. And he's seen the transformation of Mount Sinai into a learning health system, and it's creating a blueprint that I'm hoping other CIOs from different industries can learn from. Girish, thank you again for joining, and congratulations.
Thank you for all the work you're doing.
Thanks for tuning in to the Chief AI Officer podcast with Sanjay Puri. If you enjoyed this conversation, don't forget to leave a comment. We'd love to hear what you thought, and share it with someone curious about the future of AI. Join us every Friday right here on the CIO Podcast as we share more stories and insights from the leaders shaping what's ahead.